Hey everyone, and welcome back to the Masterclass. I am absolutely thrilled to have you here with me today. Get ready, because we are diving deep into two totally fascinating and honestly highly complex areas of inpatient coding. Today, we're going to crack the code on major diagnostic categories 08 and 09. That's the musculoskeletal system and the integumentary or skin and breast systems. These categories are absolute powerhouses when it comes to hospital revenue and clinical documentation, so we really need to be sharp. Okay, let's dive right into this explainer and master these systems.
But first, a quick reminder, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, before we jump into today's fresh material, let's just take a second to recap our previous lesson. So in part 46, we unpacked MDC 06 and 07, which covered the intricate coding rules for the digestive and hepatobiliary systems. We looked at everything from lap colds to complex liver biopsies. Today, though, we're shifting gears from the gut straight to the bones, joints, and skin.
Here is our roadmap for today's explainer. 1. MDC 08, the musculoskeletal system. 2. MDC 09, skin and breast. 3. CDI specificity. And 4. Our summary and next steps.
Section 1. MDC 08, the musculoskeletal system.
Now notice the sheer volume of high acuity cases we see here. The primary conditions that funnel into MDC 08 are incredibly common, but man, they can be clinically complex. We are looking at widespread conditions like osteoarthritis, which, as you know, often leads to joint replacements. We also code a vast array of fractures, and here's the kicker. We have to distinguish if they are traumatic or pathologic. Then we've got infectious processes like osteomyelitis and septic arthritis, sitting right alongside chronic back disorders like spinal stenosis and disc herniation. Each one of these diagnoses essentially sets the stage for a very specific DRG path.
When it comes to the surgical side of MDC 08, we are dealing with heavy-hitting, resource-intensive procedures. We're talking about major joint replacements, which group to DRGs 469 and 470, and complex spinal fusions, which land in DRGs 453 through 460. We also see open reduction internal fixations, or ORIFs, for fractures as well as amputations. So the absolutely crucial point here is understanding the drivers of these DRGs. The DRG weight and therefore the hospital's reimbursement shifts drastically based on highly specific details. Is that joint replacement primary, or is it a revision? Is it a total arthroplasty or just a partial one? And of course, the presence of secondary diagnoses acting as CCs or MCs plays a massive role in tiering the final payment.
Let's look at how we classify amputations. According to the ICD-10 PCS guidelines, detachment is defined specifically as cutting off all or a portion of the upper or lower extremities. For example, a transmetatarsal amputation of the foot at the left big toe, or a fifth-ray carpometacarpal joint amputation of the hand, both of those code directly to detachment. It's a highly specific root operation, and it's reserved exclusively for extremities. So let's actually see how this builds a complete code using the PCS tables. It's kind of like putting together a puzzle. Notice the structure here. We start with section 0 for medical and surgical. The body system is Y for anatomical regions, lower extremities. The root operation is 6 for detachment. Now look at that fourth character, the body part. Here we select C for upper leg right. The approach is 0 for open. The device is 0 for no device. And finally, the qualifier is 3 for low. You put it all together, and an open, low detachment of the right upper leg translates into the precise alphanumeric code 0Y6C0Z3. Every single character matters.
Section 2. MDC 09, skin and breast.
Okay, now that we've conquered bones and joints, let's shift our focus to the distinct clinical scope of MDC 09. The key diagnoses here range from common infections to absolute life-threatening emergencies. We frequently code severe cellulitis, pressure injuries, and chronic non-healing wounds. But we also see high-severity conditions like necrotizing fasciitis, which is a severe, rapidly progressing infection of the fascia that requires immediate, aggressive surgical intervention. Breast malignancies also fall squarely right into this major diagnostic category.
Now, how do these cases partition into DRGs? Well, it basically splits into medical and surgical management.
On the medical side, we have DRGs for conditions managed conservatively, like severe cellulitis, which falls into DRGs 573 to 575 based on CCs and MCCs, alongside trauma to the skin and medical management of pressure ulcers. Contrast that with the surgical DRGs. If a patient with necrotizing fasciitis or severe ulcer goes to the OR, the DRG is completely driven by surgical interventions like excisional debridement, skin grafts, mastectomies, lumpectomies, or complex tissue flap reconstructions. The presence of these major OR procedures completely changes the DRG pathway.
Section 3. CDI and Clinical Documentation Specificity. We are now entering the climax of today's lesson, CDI. Because let's be real, knowing the codes is only half the battle. Let's look at fracture documentation. I literally cannot stress this enough. Vague documentation destroys data quality and it destroys reimbursement. A coder has to know if a fracture is traumatic, meaning caused by an injury, or pathologic, perhaps due to underlying osteoporosis or a malignancy like bone metastasis. But it doesn't stop there. We need the exact anatomical site, like the specific bone in the femur or tibia. We absolutely must have laterality, left, right, or bilateral. And we need the clinical status. Is it displaced or non-displaced? Is it an open or closed fracture? Missing elements like laterality or displacement status forces coders to use unspecified codes. And trust me, that severely impacts hospital reimbursement and raises major red flags in quality audits.
Moving on to debridement. These two terms get confused constantly in clinical notes, yet they have vastly different coding implications. The absolute crucial point here is that the tool and the action dictate the code. Excisional debridement involves the sharp, cutting, surgical removal of devitalized tissue using instruments like a scalpel or a blade. It meets the precise definition of the PCS root operation excision. Non-excisional debridement, on the other hand, involves non-operative brushing, washing, irrigating, or scraping. Think of tools like a Varsajet, ultrasound, whirlpool, or mechanical scrubbing. These map to the root operation extraction. You can never assume. You must look at the operative report to see exactly how the tissue was removed.
And building right on top of the excisional tool, we have the depth of the debridement. In ICD-10 PCS, you don't just code that a debridement happened, you must code the deepest layer of tissue excised. Did the surgeon only remove skin? Did they go down into the subcutaneous tissue? Did they excise infected muscle and fascia? Or did they have to cut all the way down to the bone, tendon, or ligament? Coders have to review the operative report and query the physician if necessary for the absolute deepest level of tissue excised because this directly dictates the specific body part character used in the PCS code.
Now let's move to MDC 09 documentation and talk about ulcers. There is a critical clinical distinction between pressure and non-pressure ulcers. Pressure ulcers, which are commonly known as bed sores, are caused primarily by prolonged pressure on the skin. You'll often see this in patients confined to a bed or a wheelchair. Non-pressure ulcers, however, have entirely different etiologies. They are caused by underlying vascular or systemic conditions like poor circulation, venous or arterial insufficiency, or diabetes, leading to diabetic or neurotrophic ulcers. Skin tears and excessive moisture also cause non-pressure ulcers. The takeaway? We simply cannot code a diabetic foot ulcer the same way we code a pressure bed sore on the sacrum.
When a true pressure injury is documented, coders basically have a strict checklist they've got to fulfill. First is staging. Is it stage 1, 2, 3, or 4? Or is it clinically unstageable or a deep tissue injury known as DTI? Next, we must verify the precise anatomical site. Finally, and this is a big one, guys, we must confirm the present on admission or POA status. Was this ulcer present when the patient literally walked through the hospital doors? If so, that's POA-Y. Or did it develop during the hospital stay? That's POA-N. Capturing the POA status is non-negotiable for quality reporting. If a severe pressure ulcer is hospital-acquired, it results in a non-payment penalty for that condition. No one wants that.
Consider these before and after clinical scenarios. If a physician just writes wound infection, well, that's vague, but post-procedural surgical site infection of the sternum due to Staph aureus, now that is a specific, codable diagnosis that clearly links the cause in the organism. Acute kidney injury becomes acute kidney injury due to dehydration stage 2. And my personal favorite, chest pain is just a symptom, right? If tests confirm an MI, the documentation must explicitly state acute inferior wall MI. This level of specific documentation makes a chart completely query-proof and financially accurate, securing the correct DRG from the very start.
Section 4. Summary and next steps.
Wow, we have covered a massive amount of ground today, so here are your key takeaways for today's masterclass. Remember, MDC-08 DRGs are heavily driven by the exact type of joint replacement and granular fracture specificity. Laterality, site, and displacement are absolutely key. Over in MDC-09, your DRG hinges on the exact definitions of debreathing and meticulous ulcer staging. Never ever assume encoding. You must verify, and if necessary, query for excisional versus non-excisional tools and the deepest tissue depth excised. And finally, always confirm the present on admission status to ensure compliance and avoid those costly hospital-acquired condition penalties.
You all did fantastic today. In our next explainer, part 48 of the masterclass, things are going to get even more interesting. We are going to tackle MDC-10 and MDC-11, diving headfirst into the endocrine, nutritional, metabolic, and kidney and urinary systems. We'll be talking severe diabetes complications, acute renal failure, and pretty much everything in between. You definitely will not want to miss it.
As we sign off today, I do have to ask, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I want to leave you with one final provocative thought as you go back to your charts today. Look closely at your physician notes. Is your facility's documentation truly query-proof? Really think about it. Thanks so much for joining me, and I'll see you in part 48.